proceed.
First, congratulations for preparing this big webinar conference. Again, congratulations. Okay, today I'm Dr. Sang-Gyu Song from South Korea. Today my topic is the significance of UBE in the history of spinal surgery. Okay, we are all spine clinician and surgeon. First, diagnosis, what is patient problem, prescribe medicine or to operate disease. Finally, to rehabilitate patient who enables to return the society. Also, we know two main functions of spine. First, axis with motion, joint and muscle is very important. Second, neural decompression. During for long time of spine surgery, we have had one gain with the other loss, because neural decompression through destructive approach space. But my proposal and your proposal is one gain without the other loss. So finally, the better patient care is the doctor's future. Until now and from now, I will compare traditional care ERAS system, decompressive surgery, functional surgery, destructive, less invasive, disease-oriented doctor side, surgery safe until now, but from now, we must preparing symptom-oriented patient side, better patient care. So today I prepared the table of content. First, the general stream of surgery. Second, difference of surgical anatomy. Third, UBE is a reasonable endoscopic procedure for complicated and hard cases. The first content, the stream of the surgery, we all know, open surgery, microsurgery, endoscopy, robotic, next others, this one. Especially in abdominal surgery, first we experience the open and microsurgery. So two types of endoscopy. First, one tube system, gastroscopy or colonoscopy, single tube diagnosis, small resection. But the other type of endoscopic surgery, laparoscopy, multiportal big surgery. This is the most popular procedure. So also in laparoscopy can do everything in abdominal surgery. Now some hospital has a robotic surgery, multiportal, and robotic surgery is based on multiportal system, laparoscopic surgery. Orthopedic surgery also open and microsurgery. In beginning stage of knee arthroscopy, first diagnosis arthroscopy, single portal, but now general arthroscopy have a multiportal system. The most popular arthroscopy system, cavitary, extracavitary. Diagnosis also, even reconstruction is possible, In spine surgery, often nowadays, microsurgery is the best, the most popular procedure, but also in spine surgery, endoscopy, two-type endoscopy developed. The first one portal system, original endoscopic procedure is one portal system, PELD, one portal tubular system, mainly discectomy, but now MED or PSLD can do stenosis and endoscopic fusion, but UBE is different system, multiportal system, but one portal system has a tubular system, but UBE is non or semi-tubular system. So semi-tubular system has a big benefit, no visual or motional limitation. So UBE has the same indication as open surgery, less or minimal invasive. So I hope UBE become a cornerstone of robotic surgery. Nowadays, microsurgery is a gold standard, almost all spine, but endoscopic, maybe about 5%, only 5% spine surgery. But you know, UBE is defined endoscope-assisted microsurgery. So UBE help to conversion of microsurgery into endoscope surgery. So UBE become a cornerstone of the surgery. The significance of UBE is a stepping stone to go to the next stage in spine surgery. Second content is the difference of surgical anatomy. This paragraph of microsurgery, endoscopic surgery, the goal of surgery is same, but the most big difference of the location of lens and light source. In microscopy, lens is outside, but endoscope inside the near lesion. So main concerning of anatomy is approach in microsurgery, but in endoscopy, lesion itself. Operating time also different. Operating time is approach decompression in microsurgery, but endoscopy almost decompression. Terminology is different. In dissection in microsurgery, percutaneous or trans-soft tissue in endoscopy. But in clinical application, we must know our patient has distorted and changed anatomy. So almost all disease is abnormal change of structure. So we must check abnormal anatomy in preoperative stage. That is very important, I think. This picture is a very important, very famous figure. This is a typical figure of ULBD, basic technique of stenosis. But this figure is concerning only decompression, laminotomy, and phlebectomy. But my concerning is skin to lamina. So this is only decompression, but my concerning is to saving the soft tissue to skin to lamina. So UBE is defined trans-soft tissue approach. Okay. Spine is weight-bearing state in whole life. So I always try to preserve the soft tissue, especially muscles. So UBE is trans-soft tissue approach. That means to save the trans-soft tissue, skin, subcu, and muscle. Also, UBE also semi-tubular system. This one, left hand take endoscope, right hand instrument, but should always take the semi-tubular retractor. Semi-tubular retractor is very powerful to help to save the soft tissue. This one. Okay, this is a new main concept of UBE. If you have the enough initial working space in UBE, next step is same as microsurgery. So we must understand the initial working space is UBE. We call this zone space. All endoscopic and MIS benefit procedure require some internal operating space to work on. But unfortunately, there is no visible enough space to make surgical action in spine structure. The most conceptual differentiation of true UBE procedure to have to make a space. There are two potential space to obtain posterior of spine. First, multifidus triangle. Second, a potential space between lamina and muscle. These potential spaces are separated and widened by special designed tools. So hydrostatic pressure and mechanical retractor and can widen potential space and finally make an enlarged working space. This enlarged working space is called the sonde space. For example, as a potential peritoneal cavity can change enlarged working cavity with carbon dioxide in laparoscopy to potential space in spine can be converted into enlarged working space with hydrostatic pressure and mechanical retraction of UBE. These two potential space, this one here, multipedus is the assembly of small muscles. This one, small muscle fascicle. Small slit, this triangle, we call this is multipedus triangle. This one, this is CT, coronal CT scan. You can see here, star shape here. This one, potential space between lamina and muscle. These two potential spaces can be converted into working space. This is the main concept. This one here, hydrostatic, this one, hydrostatic pressure, mechanical retraction is two main forces to make enlarged space. This area, this area is sonde space here. This is a difference between left and right standing here. First, left standing and left ULBD, this is almost all cases. But this one, this is the left standing and right laminotomy. This one, HMP, right ruptured. Commonly in conventional surgery, right side lesion, right stand, left side, left stand. But in UBE, my style is right ruptured disc. I stand the left side. I will approach right laminotomy because I try to preserve the muscle, this muscle. So right standing, right ULBD, this is only stenosis, left foraminal stenosis. Commonly, patient has combined stenosis, central stenosis and foraminal stenosis. The central stenosis with left foraminal stenosis, I stand, right stand, and right ULB. But this standing can make more damage this muscle because of the instrument and this muscle direction is vertical. So I like to stand left side commonly. This also difference between left and right standing here. This one here, left standing, this is we are all spine surgeons, we are know the anatomy of spine. The lamina is this type three-dimensionally. So this is the here above lamina, this area is working space also. This area, scope and lamina is vertical. So we left standing has right relatively wide lamina, less soft tissue and better orientation, comfortable use of retractor, easy bone drilling. But this is right standing here. This right source and lamina is long angled. So narrow initial workings from sloped view of lamina, more soft tissue in interlamina space. So more damage on muscle, slight difference. This one is initial working space. This is concept. Here, lamina, and important thing is this retractor, semi-tubular retractor. Retractor can make more wide. This is initial working space. This is left standing of left ULBD, but this type here, right stand, right approach here, blood washed, and this one, lamina, and retractor also. This is initial working space in right ULBD, slightly different. Also, I always emphasize the endoscopic surgical anatomy. These all is endoscopic anatomy for central stenosis. height gap between disc and interlaminar, height gap between disc and interlaminar space, multifidus anatomy, arteries above lamina, rotator longus muscle, the shape of lamina, spinal process, ligament, especially ligament flavum. Ligament flavum is the most important endoscopic surgical anatomy in UBE. You know, superficial and deep layer, midline cleft, fiber direction, always transversal learning this type. The tubercle of anterior surface of upper lamina, bony junction between upper border of lower lamina and medial margin of pedicle. This is very important because just below this bony junction, the traversing root is lying. So I always try to check the bony junction and remove bony junction. I can find the root easily. That's important. Also, epidural venous fluxus, but where is the common bleeding focus? We must check the also for compression factor traversing root. This one finally sometimes engorged connecting vein between foramen and lateral access. Engorged connecting vein across the traversing root. Sometimes engorged vein must be removed for decompression. But last content, UBE is a reasonable endoscopy procedure for complicated and hard cases. First, multi-level stenosis in 8% because long incision, big muscular damage, long time. Second, revision surgery, adhesion, dural tear, incomplete decompression. 3, L5 is on extra-foraminal stenosis. Sometimes misdiagnosis, deep and very narrow, incomplete decompression. For central foraminal combined stenosis, sometimes joint violation, 2 procedure on fusion. 5, high lumbar narrow lamina, sometimes heterogeneous lysis and retraction injury nerve root. Finally, endoscopy lumbar interbody fusion for multiple level and adult degenerative kyphoscoliosis. This is but endoscopic lumbar fusion is a beginning stage, but so long time. So if you have a big experience of endoscopy lumbar interfusion, you can do deformity, I think. Finally, thoracic hard and huge disc with myelopathy. These all cases is difficult even in microsurgery, but UBE can do this. Hard case is relatively easy. Okay. I explain first case by case. First case is multiple level stenosis in elderly patients. Almost all elderly patients have multiple level stenosis. In my case, one level, 30 or 40 minutes, but multiple level, no problem. But also less change of hemoglobin, less muscular damage, ambulation period 1 day. This is preoperative, postoperative. So if patient, this multiple stenosis can operate it in microsurgery, long muscular incision, maybe post-operative care is for a long time for difficult, I think. This case, revision case, first, in revision case, 2 problems. First, adhesion. Second, where is the root? So I always also commonly in microsurgery, we have adhesional lysis to check the pressure dura, but I always think about adhesion tissue is my friend. Adhesion tissue is not to be removed, and adhesion tissue can be protective dura. Second, this one here, this is first surgery, rupture, post-operative, but this is decompression, but ruptured recurred hernia disc. This area, dark signal, this is adhesion tissue. This is prepared. That means I don't remove adhesion tissue. I always think use the adhesion tissue as a dural protector, this one. So I think I changed my concept. Adhesion tissue is my friend to protect the dura. Second issue is the adhesion make me to check the dura difficult. So I always, if you have early detection of the traversing root, next step is very comfortable. So where is the root? So I think you know that the traversing root learning the pedicle. So medial wall of pedicle is that means medial wall of pedicle means the lateral border of root. So medial wall of pedicle should be checked at first. This area has a less adhesion. That means the medial wall pedicle means root should be checked at first. This one here. So two issue. Third is L5S1 extra-foraminal stenosis. We know we have the many cases of Feldbeck syndrome. Main focus of incomplete neural decompression is L5S1 foraminal and extra-foraminal stenosis. But sometimes so accurate diagnosis important. We have the many misdiagnosis. So accurate diagnosis is based on first symptom L5 root symptom, second Allah sign power band that here. This is sagittal view of MRI. Here, this is L5S1 foramin extraforamin area, but traversing this type dark signal. This one, this is contact to upper border dura and here the joint here. So L5 root learn go out through lumbosacral tunnel, but this power band divided lumbosacral two tunnel, upper tunnel, lower tunnel divided two tunnels. So in extraforaminal stenosis, root learning, root go out through low lumbosacral tunnel. We must remove power band completely. This one here, this is power band, this is completely removed power band, root is free. Second sign is the Allah sign. This is left Allah is the bright signal, but this dark signal. This dark signal means dark signal is calcified Allah. This is we call Allah sign. This means maybe extraforaminal stenosis. So this one preoperative post over here. So also we finally, if you remove completely extraforaminal stenosis, we must go the other. Okay, we commonly use the Kenbin triangle, but Kenbin triangle here, this one root medial side, but this commonly foraminal area is very easy through Kenbin triangle, but here root lateral side transverse process here lumbosacral ligament and this root, this here, this area is we call Sonja triangle. This means here bright height ligament. This is power band. Always we check the Sonja triangle. I always go into through Sonja triangle to remove power band. This one here, power band. This one. After removal, power band. Maybe complete neural decompression is possible. For central foraminal combined stenosis, common type here, this one, central stenosis foraminal combined, approach this type. One time, this one, here, this one. This is the contralateral approach is the most very big benefit of endoscopic surgery comparing to microsurgery. This one, high lumbar and narrow laminar. Also this one, this is L12, central ruptured disc. Here, this one, commonly we approach interlaminar, but sometimes the possibility of iatrogenic lysis and root retraction, this type I approach through trans-foraminal approach, this type. At that time, I use 0 degree, sometimes 30 degree, this one. This is the benefit of endoscopy. 6, endoscopic lumbar interfusion for multiple level adult degenerative kyphosis. This one, okay. Almost all spine surgeons concerned about fusion rate. For fusion, increasing fusion rate, bleeding endoplate, and much more harvest bone important, you know that. But also important thing is the big lordosis, how to make a big lordosis. First, we must check disc angle, cage size, location, screw reduction. But after mastering this fusion rate and lordosis, you can try to multiple level fusion like this one. This is multiple level fusion, this type. This is adult degenerative kyphoscoliosis, this type. This is preoperative, this postoperative, this type. So again, this is fusion surgery. The basic concept is the fusion rate and lordosis. After mastering two basics, you can do multiple level and adult deformity, I think. This is thoracic heart and huge case myelopathy. This approach is a modified lateral extracavitary approach, this time. Here, this is old compression fracture, huge rupture disc, this type. This is a preoperative, postoperative, this type. So at that time, I use 0 and 30 degree. Especially coda equina syndrome and in code level, we know first internal decompression, first decompression, first, second removal of disc. This is an important concept. In my conclusion, our future, the significance of UBE is a stepping stone to go to the next stage in spine surgery. Also, let's think about what should I do for better patient care? What should I prepare for coming fourth revolution period? Thank you everyone. Thank you.